Good afternoon. For today's CU session, we'll be looking at the critical appraisal of a systematic review using the AMSTAR 2 checklist. The Government of India is a signatory to the United Nations Sustainable Development Goals, which adopted a global maternal mortality ratio of less than 70 deaths per 100,000 live births by 2030. From 2017 data, the UN estimated that about 24 million children were born and about 35,000 mothers died during childbirth or shortly thereafter, giving an MMR of 145 per 100,000 live births. This is a picture of the states in India. The ones in the light yellow actually have a low MMR as compared to the ones in the orange and dark red. They have a higher MMR rates in India. Those states are actually called the Empowered Action Group states. Its acronym is called EAGA, which basically stands for Empowered Action Group plus Assam. The states which actually come under this is Uttar Pradesh, Uttarakhand, Bihar, Jharkhand, Madhya Pradesh, Chhattisgarh, Rajasthan, Orissa, and Assam. So you are attending an event in which there are policymakers, public health experts, and other medical professionals to deliberate on the causes behind India's high MMR. And our goal is now to chart an evidence-based roadmap for rapid improvement. The optimistic news is that compared to 1998 to 2018, overall the trend in the MMR has, there's a drop in the MMR rates. The ones in the blue lines are the EAGA states, and the ones in the orange are the other states. Towards the right, we have the ones with lower MMR rates, that is Tamil Nadu, Maharashtra, and Kerala. If you look at the data from India from 2007 to 2014, actually the most common cause of maternal death is hemorrhage, which contributes about 47%. After that, we have sepsis, which contributes about 11.7%. Then we have hypertensive diseases in pregnancy. These are all indirect causes. Like, for example, patients who already had a heart failure, which has been exacerbated during pregnancy. This light gray actually belongs to the other obstetric causes, like, for example, obstructed labor, which results in death. If you look at the Tamil Nadu, Kerala, where the MMR rates are low, hemorrhage is less, but more chunk is contributed by the hypertensive diseases. But in the EAG states, hemorrhage is more, and also the sepsis rate is also quite high. So one of our thoughts was, if we target the sepsis, we can prevent or treat sepsis, will that reduce the MMR? So our target question now is, can the risk of maternal sepsis be reduced by administering antibiotics prophylactically before infection occurs? So if you look at the WHO 2015 guidelines, antibiotic prophylaxis is not routinely recommended during labor for a normal delivery. Only if patients have vaginal group B streptococcus colonization do we actually give prophylactic antibiotics. Even if the patient has meconium-stained amniotic fluid, we don't actually advise antibiotic prophylaxis. Recently, the WHO has revised its policy and has told you can use antibiotics even for patients who have a operative vaginal birth. For example, if they have forceps or vacuum-assisted delivery. So this systematic study was done by Suzuki et al. They titled it "The Effects of Antibiotic Prophylaxis During Labor on Maternal and Neonatal Outcomes in Women Planning Vaginal Birth." So they have done this actually to guide the WHO in revising its policy, whether to implement giving routine antibiotic prophylaxis for patients just planning a vaginal birth with no other indication. Now, before we go ahead with the appraisal, just wanted to highlight the tools which specify the standard for systematic review. So we have some tools which actually fall under the reporting standards. For example, what we use of now is the PRISMA 2020. Then we have methodological standards, tools which assess the methodological standards. Here we'll be using the AMSTAR 2 checklist. Then we have some tools which actually look at the risk of bias in the individual studies. And right now we use the ROBIS tool. So methodological standards basically tell how well the review authors the ones who have conducted this systematic review, how well they have done it. Risk of bias, this one actually refers to the systematic flaws or limitations in the design, conduct or analysis of the original research, the individual RCTs, which will actually affect your final review. And reporting standards, like for example, PRISMA 2020, this actually helps systematic review authors describe the methodology they used and the results of the synthesis in sufficient detail. So AMSTAR 2 was actually developed by Dr. Beverly Julia Shia. It was initially developed in 2007, based on the Cochrane Handbook for Systematic Reviews of Intervention. So it focuses on the correct methodology to ensure reliable results. It has a brief checklist of items needed for high quality reviews. AMSTAR 2 was published in 2017, almost a decade later, after peer feedback. So here they have domain-based rating system with 7 critical domains and 9 non-critical domains. The other important thing which AMSTAR 2 has is it also has a checklist to appraise systematic reviews of non-randomized studies of interventions. So let's go ahead with the questions. So did the research question and inclusion criteria for the review include the components of FICO? So yes. So they have adequately defined the population, the intervention, comparator group, as well as the outcome. The time frame was not mentioned. So the objective was to assess the effects of antibiotic prophylaxis in women in labor after they have crossed 28 weeks of gestation, and to see the effect of it on the prevention of maternal and neonatal infections and mortality. So the population they have taken is pregnant women in labor after 28 weeks of gestation. They should be anticipating a vaginal delivery. They should not have any indication for an antibiotic prophylaxis, for example, a cesarean section. And the study was done in any care setting. So the intervention was any antibiotic prophylaxis, and the control was placebo. So they have looked at a list of outcomes, the incidence of maternal sepsis, maternal mortality, neonatal sepsis and neonatal mortality, wound infection, and the adverse effects of antibiotic, as well as the neonatal care unit admission. And the time they've not mentioned, but roughly usually sepsis, not sepsis, but usually all MMR is all checked around 6 weeks. So did the report of the review contain an explicit statement that the review methods were established prior to the conduct of the review, and did the report justify any significant deviations from the protocol? So I have given this yes, because they had a protocol which has mentioned the meta-analysis synthesis plan. And they had also given a plan to investigate causes of heterogeneity, and they had deviated from the original protocol, and they've given justification for the same. So when they conducted the review, they have followed the methodological expectations as given in the Cochrane Handbook. They reported the findings according to the PRISMA 2020 checklist, and the protocol was registered under Prospero. So usually before Cochrane publishes a systematic review, the author should actually publish the protocol, which is then continued as a study. Here, because they had time constraints, and because of urgency in the nature where they have to advise the WHO, they have mentioned that this protocol was not published in, prior, but they had registered in Prospero. So this is what they had mentioned here. Over here in the body of the method, they had mentioned some few protocol modifications. They had added maternal satisfaction and intrapartum stillbirth as outcomes on request by the panel. They had initially planned to do a fixed effect model, but then after peer review, they have changed it to they have adopted the random effects model for analysis. And they have also introduced 2 additional subgroup analysis. They've compared between low risk and high risk cohorts, as well as preterm and full term deliveries. Did the review authors explain the selection of the study designs for inclusion in the review? So they have taken only RCTs, and this is appropriate because that's the most appropriate study design for evaluating intervention effect. So what kind of studies have they taken? So based on the type of studies, they've included all published, unpublished, and ongoing individual and cluster randomized control trials. They have excluded all quasi-RCTs and all crossover trials, which does not fit into the design. Now, based on the participants, they have taken all women at more than 20 weeks of gestation, anticipating a vaginal delivery. They've included participants irrespective of the baseline risk factors for infection, like age, comorbidity, socioeconomic status. And they have excluded trials enrolling only women with planned cesarean section, or even those trials where they have continued antibiotics as a treatment course rather than a preventive um, therapy. Now, based on intervention, they have taken any type or class of antibiotic administered prophylactically during labor. There was no restriction on the route of administration or dosage. The comparator was either a placebo or no treatment. The review included only trials investigating single dose prophylactic antibiotic administration. They have excluded studies that assessed prolonged therapeutic regimens or postnatal continuation protocols. The outcomes I have just classified as maternal outcomes, that is, incidence of maternal sepsis and incidence of maternal mortality. The neonatal outcomes were the incidence of neonatal sepsis and the incidence of neonatal mortality. The other outcomes of interest were any incidence of any wound infection, any adverse effects of antibiotics, like emergence of antibiotic resistant bacteria, any other drug adverse effects like vomiting, diarrhea. Some studies have reported pyloric stenosis in the neonate as a complication. The other important thing they had looked at was neonatal ICU admissions. Um, and they had also written as cost of care, maternal satisfaction, as well as intrapartum stillbirth. Now, did the review authors use a comprehensive literature search strategy? Here I have given a partial yes, because for the following reasons. Now, they have looked at the most important medical bibliographic databases. That is the Cochrane Central Register of Controlled Trials. They have looked at Medline, Embase, and Cinal. They've looked at trial registration sites like clinical trials as well .gov and the WHO International Clinical Trials Registry platform. They mentioned that they've looked at the reference list of all the included studies, and they've also looked at relevant systematic reviews with the same question. And they have explicitly mentioned that there was no language restriction. Some of why I gave only partial yes was they had not searched for grey literature, like for example, any conference abstracts and thesis abstracts, and they've not mentioned whether they had contacted any content specialists also, content experts. Here is in the supplementary material they had given their search strategies. Now, did the review authors perform study selection duplicate? Yes, they have done that. So this is the procedure how they screen studies. They had managed it using EndNote. For screening, they had pairs of authors independently evaluate the titles and abstracts against the eligibility criteria. And two screening authors discussed any disagreements during the selection process. So all the duplicate records were identified and removed. And subsequently, all the full text articles of potentially relevant studies were reviewed independently by the same authors. And if the consensus could not be reached, a third review author was consulted to make a final decision. Did the review authors perform data extraction duplicate? So yes, so they have mentioned that working independently, two or more authors conducted data extraction using Microsoft Excel. They did not use other sophisticated softwares like Covidence. Then data extraction was collaborative with discussions between two authors and consultation with a third when disagreements arose. Did the review authors provide a list of excluded studies and justify the exclusion? So yes, they have given a Prisma diagram and they've also justified the reasons for exclusion. The Prisma diagram was a bit basic. They had not mentioned from which databases they had got the records. They had just overall pulled it together and told they had got about 6,678 records through database searching, and they had identified two records through other sources. So, a total, they had got 6,680 records. After duplication, so duplicates were removed, they had 5,235. And they had to exclude about 5,171 because of irrelevancy. Then they finally had 65 full text reports. Out of the 35 full text articles that were excluded as irrelevant, and three reports they have given reasons why they had excluded it. And they were left with four studies, and two more studies which were awaiting classification, and three other studies were ongoing. So finally, for this meta-analysis, they had taken four studies. So if you look at the characteristics of the excluded studies, one study they had given the antibiotics during gestation and not during labor. The second study they had eliminated because of ineligible study design. They realized that the study was a quasi-randomized control trial. And the third study they had again excluded because of the ineligible population. All the participants were pre-labor. These are the study characteristics of those studies which were awaiting classification. One study, they could not access the abstract or full text report for the study. The second study, they have mentioned that antibiotics were given but was not specified. Did the review authors describe the included studies in adequate detail? So I gave it a yes because they have described the population as well as the intervention in great detail, and the comparator was mentioned, and they have also described the study setting as well as the time frame for follow-up, and all conflicts of interest also was mentioned. So if you look at the four studies, three of them were two-arm placebo-controlled RCTs. The study done by Dr. Subramaniam et al. Was a three-arm placebo-controlled RCT. They had a total sample size of about 42,846 participants. I would just briefly like to mention the important aspects of each of the four studies. The first study was Oloolana in 2017. So this was an RCT. And they have given here a single 2-gram dose of oral azithromycin. This study was actually done in Gambia. These are the outcomes that they had looked at. Maternal sepsis, maternal mortality, neonatal sepsis, neonatal mortality. And this study has looked at the antimicrobial resistance. So they have written the outcome measures would be the proportion of bacterial isolates from the maternal and neonatal nasal swabs, breast milk, and vaginal swabs showing resistance or intermediate susceptibility to azithromycin. Yeah. Then the next study was by Roca 2023. So here also they have given a single 2-gram dose of oral azithromycin. These are all the outcomes that they have looked at. They have not looked at any antimicrobial resistance. This study was done in Gambia and Burkina Faso. The next study was by Subramaniam in 2021. So in this RCT, they had actually 3 arms. One arm got placebo. The second arm got a single 1-gram dose of oral azithromycin. The third group got a single 1-gram dose of oral azithromycin plus 2 grams of oral amoxicillin. And this was done in Cameroon. The theta study, this is also called the A+ study. So here they have given 2 grams of oral azithromycin, and they have looked at a lot of outcomes. They've also looked at other maternal infections like chorioamnionitis, endometritis, mastitis or breast abscess, pyelonephritis, etc. And this was done in, it was a multi-centric study done in almost in 6 countries. I have just made a map of all the countries which were involved. So the location was actually low and middle income countries: Bangladesh, Burkina Faso, Cameroon, the Democratic Republic of Congo, Gambia, Guatemala, India, Kenya, Zambia, and Pakistan. So these all these countries are geographically spaced out. So the results of the study might not be applicable to all the other low and middle income countries or the high income countries. Now, the things which I noticed among the studies were all of them had the sepsis definition was different. Tita 2023 and Subramaniam 2021, these two studies actually use the WHO criteria, which actually includes infection, including fever, and they should have one sign of organ dysfunction. For example, they should have either a tachycardia or hypotension with a BP less than 90 millimeter mercury. They should be tachypnic with a respiratory rate more than 24 per minute. Patient would have an altered mental status or confusion or reduced urine output, jaundice, renal failure with a creatinine more than 1.2. Oloolana was more of a clinical judgment, and even ROCO was also of a clinical judgment, where if the patient had lower abdominal pain, dysuria, bacteriuria, offensive vaginal discharge, they were labeled as sepsis. The other thing which was different was Tita and Subramanian 2021. They both had used a WHO of 42 days postpartum for outcome assessment. Oloolana had actually taken 2 months postpartum as the date of assessment of outcomes. Roca had assessed all the outcomes at 28 days postpartum. Also, the neonatal sepsis definition also differed across studies. So, Theta had used the WHO criteria. The other 3 studies had also used their own individual criteria. Now, maternal mortality, neonatal mortality was defined as death from any cause, and here also the range, the date, the duration where they measured the outcomes were also different, with some differences in the time frames. Olvalana had actually looked at the antimicrobial resistance. And so they had done it immediately postpartum. Then they had also looked at it 28 days postpartum, and they had a follow-up assessment at 11 to 13 months to evaluate the persistence of resistance. The next question. So, did the review authors use a satisfactory technique for assessing the risk of bias in individual studies? So, yes. So, Cochrane has the Cochrane Risk of Bias tool for RCTs. It's called ROB2 tool. This was actually published in 2019. And they have explicitly mentioned that they have used this particular tool for the assessment of the risk of bias of the outcomes. And they have also gone through it based on the domains outlined by Chapter 8 of the Cochrane Handbook. So when you look at the risk of bias, they have five important domains. You look at the randomization process to see how well the randomization was done, whether the allocation was concealed or not. So if the patient had a computer-generated web system of randomization allocation, it was given as a low risk of bias. Or if the suppose they had used they were randomized based on the date of births, that was given as a high risk of bias. That means the randomization is not that great. Here, if you look at all the studies, there was a low risk of bias in all the studies. Then the next domain is to look for deviations from intended intervention. So see if the patients who were assigned to a particular group actually got the appropriate intervention. So here also they have given a low risk of bias for all the studies. So missing outcome data is when there is a application that's lost to follow up and how they dealt with the missing outcome data. So none of the studies there was a major loss to follow up. So they have given them all low risk of bias. Then the next uh, domain was the measurement of the outcome. Uh, so for this also, that authors have given them all a low risk of bias. Uh, but for the last domain, that is selection, the reported results, Olivarana had some concerns because the protocol, as well as the finally published paper, had some slightly different outcomes mentioned. So overall, they had given Roca, Subramanian, and Theta no concerns. But for Olivana, they had written as some concerns because of this. So did the review authors report on the sources of funding for the study review? Yes. As I showed in the baseline tables for all the four RCTs, they had clearly mentioned the funding source as well as the conflicts of interest. The next question is, if meta-analysis was performed, did the review authors use appropriate methods for statistical combination of results? So yes. So here they have applied a random effects meta-analysis model. They had chosen this because they had anticipated the clinical heterogeneity among the included trials. And they have clearly mentioned that all analysis was done according to the intention to treat principle. And they have used general inverse variance method to synthesize the results for all the numerical outcomes. And they have looked also for heterogeneity by using the chi-square and I-square statistics. And for some outcomes with inconsistent reporting, that is the antimicrobial resistance, which was reported by Olubalana, they had followed the SWIM guidelines, that is synthesis without meta-analysis narrative guidelines. So now let's move on to the results. So if you look at the first outcome of interest, that is the maternal sepsis. Yeah, so this is a forest plot. Here you have all the individual studies on the left. We have the intervention arm as well as the placebo column. And this column looks at the risk ratio. And the final, what is plotted here is a summary statistic which are actually adjusted. So in random effects, we adjust all not only for the sample set, but also we are expecting variance among the different studies. And on the very right, they have written the risk of bias of individual studies. So overall, the diamond is the pooled estimate of the weighted summaries of individual studies. And what we find is for this maternal sepsis, overall, in patients giving antibiotics, the risk ratio is only 0.65, the confidence interval of 0.56 to 0.77, showing benefit. The second outcome, that is the maternal mortality, the risk ratio is actually 1.21 and was crossing either sides of 1. So there was no major difference in the maternal mortality among both the groups. Looking at the neonatal sepsis also, there was no difference in the outcome. It was almost 1. Neonatal mortality also, there was no difference. When you look at the other maternal infections like perennial infection, patients on the antibiotic side actually had a better outcome. The risk ratio was around 0.8, but the confidence interval was almost touching 1. And there was no difference among the NICU admissions. So if the meta-analysis was performed, did the review authors assess the potential impact of the risk of bias in individual studies on the results of the meta-analysis or other evidence synthesis? So they had actually, in the original plan, they had planned to do sensitivity analysis. If at all they got studies with high risk of bias, and they would exclude them. And even if they had got cluster randomized trial, they would have excluded them and done a sensitivity analysis. But here they did not review because none of the included studies seem to be at a high risk of additional selection bias. But yeah, the other things they could have done was based on the days of outcome assessment, because some studies had looked at the outcome assessment at 28 days, but deaths may not have occurred. And some studies had looked at days which are around 58 days postpartum. So whether any analysis could have changed based on the days of outcome assessment, that could have been one. And whether they could have done a fixed effect model also as part of the sensitivity analysis. Did the review authors account for risk of bias in individual studies when interpreting or discussing the results of the review? So they have clearly mentioned that they have used a grade, and the grade has actually incorporated risk of bias assessment. So I have given it a yes. So this is the summary of findings.
Okay, so they basically look at the statement, your objective. They look at the PICO, and here is the first outcome. So the risk with placebo is 18 per 1,000. The risk with any antibiotics is 12 per 1,000, the sepsis. The relative effect was, risk ratio was around 0.65. The certainty of evidence here is called the grade. So this basically looks at the indirectness, the imprecision, the risk of bias, any publication bias. Here they have actually downgraded by 1. Because of this Olvanana study, which had actually showed there were some concerns in the risk. So that's why they have downgraded 1. So they labeled it as moderate evidence. Then the second one, maternal mortality, here they have not showed any difference. Here also they have put it as moderate recommendations. Why? Because they have downgraded this for imprecision. So they had actually taken 0.75 to 1.25 as minimally important difference. If the confidence interval crossed that 0.75 to 1.25, they have labeled it as imprecise. That's why neonatal sepsis, even though that shows no difference, all graded as high, because the confidence interval is less than the minimally important difference. So they've written here, we used a pre-specified range of risk ratio, relative risk 0.75 to 1.25 as the minimally important difference threshold when assessing imprecision. So this is basically the antibiotic antimicrobial resistance. I won't go into much detail of this. It just suffices to know that in the beginning, they found that the number of azithromycin resistant group B streptococcus was more in the antibiotic arm. But then by 11 to 13 months, it had all cleared. So there was no long-term antibiotic resistance. But they have put it as very low-grade evidence for this. For NICO also, there was no difference, high grade of high certainty evidence. So next thing is, if there was any heterogeneity, did they explain the heterogeneity? So here in our study, as I showed you, there was no significant heterogeneity in any of the results. So they didn't explain it. The next thing is, did they look at the publication bias? So our studies were only 4. If it was more than 10, they could have shown a funnel plot. So because it was less than 4, they have not showed a funnel plot. The next thing is, they have also looked at the selective outcome reporting as a publication bias, which Olivalana had. And have the authors of the review, not the individual study authors, but the overall systematic review authors, do they have any funding conflict of interest? So they have reported no competing interest, and they've showed their funding paper. So that's the end of AMSTAR. So overall, I would give this a very highly good methodological score for this paper. The last part of it, will the results help locally? I've taken the CAST questionnaire. So can the results of the systematic review be applied to a local population in local context? I would say I couldn't tell. If you look at the only study which actually contributed to the effect was the TETA study in 2013. Actually, they had almost more than half of the patients are actually from Asian countries, which was Bangladesh and Pakistan and India. And if you look at the overall global bugs which actually cause maternal sepsis, one is E. coli, the other one is the streptococcus, staphylococcus, and Kleb. If you look at our Indian data, I found one study from Maharashtra. I couldn't see the full text. What they reported was Klebsiella, Staphylococcus, Pseudomonas, Proteus, Streptococcus, and cons. Important thing to know is every site actually has different AMR resistance patterns. Everywhere the infection prevalence is different, and the obstetric care practice is also different in every study. So I don't think we can really pool the data to everything. Are the benefits worth the harm and cost? Here also I couldn't really tell. Sorry? The baselines being different? It could be because each center is different. Like if so, if I look at the TETA study, I actually have their so if you look at their baseline characteristics here. Yeah, I would say roughly the population per se, but then we cannot compare CMC. Like our tertiary care centers, like this one. I would say it's mostly like CMC, because actually more than 50% of the population were actually well educated. They got about more than 7 years of schooling. Yeah.
You know which state in India this was? TETA?
So they have taken 4 places. One is Sevagram. One is forgot the sport.
But not South India.
Not North Indian things.
Well, answer depends. If you are somebody from one of those AGEP states, then it may apply.
May apply.
But it may not apply for some. May not.
But I'm saying we cannot standardize to the whole of India. Next thing, other benefits, what the harms and costs. So if you look at the adverse effects, diarrhea and vomiting, there was actually no difference. In fact, it actually favors there was more side effects in the placebo group than the antibiotic group. If you look at the cost-wise, so the risk with placebo was 18 per 1,000, that is 1.8%. Risk with antibiotics was 12 per 1,000, that is 1.2%. The risk difference actually reduced by 0.6%. If you look at the number needed to treat, you needed to treat 166 pregnant ladies to actually prevent 1 maternal sepsis. If you look at the cost of 2 gram azithromycin is 96 rupees. So the cost to prevent actually 1 maternal sepsis is only 15,000 rupees, 936.
You said one of the outcomes in the systematic review was cost.
Yes. So actually only TETA is the only study which actually had reported cost. So they have not put that in this, published it.
That is why they downgraded TETA.
And no, they not downgraded TETA study. No. They have put it in their narrative. They've just described it. But the important thing about harms is there's no data actually on antimicrobial resistance. The data for that was actually very low quality evidence. So that's the actually great harm. We shouldn't shoot ourselves in the foot by prescribing azithromycin and then developing azithromycin resistance later. So would the experimental intervention provide greater value? It's a single dose of azithromycin. So would the experimental intervention provide greater value to the people in your care? Why I would say no, why I would not recommend this, number one, antimicrobial resistance is uncertain. So we don't know the long-term healthcare implications of rolling this out on a national basis. Number two is we have a lot of data actually which shows that India has increasing macrolide resistance, especially post-COVID. And third thing is there was actually no effect on maternal mortality and neonatal mortality. Even though the sepsis reduced, it didn't translate to improved maternal mortality rates. Next thing, if you look at the 2017 data, 22 million live births happen in India. So if you want to give azithromycin to everybody, government has to spend about 240 crores. So is this really beneficial? This is the CMC value. Yeah. So what I would say is better to invest in clean delivery practices, infrastructure, blood bank education, because hemorrhage is the most common cause for maternal mortality, and staffing. And maybe you can consider use in rural or peri-urban areas where the actual sepsis rate is higher as compared to your tertiary care centers or healthcare that's already low maternal mortality rate. And these are all the existing schemes which India has already rolled out for the pregnant ladies. Thank you.